Quick good morning or good afternoon, I should say, and welcome to everybody who's made it online today. Thank you very much for taking time out of your busy schedules to join us for this final in a series of webinars for our Get Rare Aware campaign around newborn screening. For your information, this webinar will be recorded or is being recorded. And if you do have any questions, please use the Q&A function. We'd love to hear from people if they have any questions around what's being discussed today. I'm delighted to say that we have Professor Ahmad Monavari with us today, a metabolic specialist from Temple Street Children's Hospital, who wears many hats in addition to being, I guess, a clinician managing patients. He also deals quite closely with the newborn screening governance group and with newborn screening in general in the Children's Hospital and the labs and stuff like that. So I look forward to having a conversation with him. But before we get into that, first off, I'd like to thank our sponsors, Roche, who have been working with us on this project. And without their support, we wouldn't be able to do the Get Rare Aware campaign. The campaign, I guess the overarching aim of Get Rare Aware is to raise awareness for rare diseases generally. Last year, we ran a campaign around diagnostics and genetic services more specifically, and this year we're on newborn screening, and who knows what topic we will pick up for next year. But really, I guess the really important overarching goal is that we ensure that our people in positions of leadership across the HSE and in political circles, be they TD, senators, working with the government, government members, that they all have a much better awareness around people living with rare diseases, that they recognize some of the challenges, that they can hear about some of the opportunities in terms of better care, better diagnosis, improved access to treatments, but that they have a better overall understanding of people living with rare diseases, the challenges that we face, and what needs to be done to overcome some of these hurdles and barriers. Last year's campaign was successful as far as we were concerned. There was over 6,000 emails sent, and we generated in excess of 50 parliamentary questions. And some of the topics are still going on. In fact, independent TD Dennis Naughton even raised awareness yesterday in the Dáil around genetic services and where's the new home for the genetics lab, which has always been housed in Crumlin, but obviously that's moving to the new Children's Hospital, the hospital overall, but the genetics lab hasn't been given a home in the new hospital. So he has been banging the table on that for us in the Dáil. So I guess, I would have to say that last year's campaign was successful. We're hoping for the same type of success this year. Or even to top it. Let's be honest about it. For anybody that has an opportunity, please go onto the website getrareaware.ie and take action. It's really simple and straightforward. You just put in your name and an email address, and it will send emails to your local elected representatives, as in TDs or senators living in your region, and tell them that they really need to do something about newborn screening, and to ask them to ask the minister to get a move on. In terms of newborn screening in Ireland, I guess the advantage of newborn screening is clearly that it provides an early diagnosis. So it allows us to get in early to identify newborns and infants living with a rare disease, and to provide them with treatment before they become symptomatic. We currently screen for 9 rare diseases in our newborn screening panel. In other countries, they're screening for over 30 rare diseases. And given the challenges with diagnosing rare diseases, generally speaking, the diagnostic odyssey is something in the region of about 6 years for people living with rare diseases in Ireland. We need to do something to speed that up, and newborn screening is definitely one of the tools that would really enable early diagnosis for those affected by the conditions that are screened for. We anticipate that we could be, I guess, diagnosing newborns, up to about 200 newborns if we had a full, 30 rare disease panel. We're even asking just for the panel to be doubled at this stage. Let's get up to something around 20. Let's get to the middle of the rankings in terms of European countries. Since this government came into effect, we've had what's known as the National Screening Advisory Committee, that was a spin out from the cervical check scandal, and Gabriel Scally, I should say, recommended that there was an overarching governance structure put in place to make sure that we were methodically going through the screening programs, including newborn screening, and adjusting and amending and adding to these programs as innovations are happening, as technologies are moving on. So that group has been in place for 5 years, and over the last 5 years, 3 rare diseases have been recommended by the Screening Advisory Committee, but only one of those has actually been implemented at the HSE. So really, we need, I guess, there's 2 jobs, I guess. The first one being recommendations coming from NSAC, and the second one being implementation at the HSE. And we really need to start ramping that up. At the moment, there are 30 plus rare diseases that have been requested to be added to the newborn screening panel. And those recommendations are largely coming from clinicians, from Professor Monavari and from his colleagues across the children's hospitals. And some of them have also come from patients, from individuals living with rare diseases, or with family members with rare diseases, and from some patient organizations. But there's a huge, I guess, groundswell of support to expand newborn screening. We're hearing the right language from the government, but yet it's incredibly slow and arduous, and we really need to do something to ramp up newborn screening. Let me take a look at my notes. I think that we're at a stage now where we need to do something. We have an election coming up. We want to make sure that in the next program for government, that a target of doubling the number of rare diseases in the newborn screening panel is absolutely achievable. I'm reassured by people across the HSE that there are ways that we could jump ahead, that we could add 2, 3, or 4 conditions at a time for some of these, that we can group them together. And so really, we need to apply pressure. And I would really ask that anybody, that if you are visited by any election candidates, that you ask them about what they are doing for rare diseases, how they might be able to support newborn screening and diagnosis in general, and treatment and care for rare diseases. But let me not wander too far from the topic today, and let me bring in Ahmad. Thank you very much for coming along today. I know you have a busy schedule, as do most of your clinician colleagues. You're all working on various areas and tasks and stuff. But let me just start by asking you to give me a little bit of your background. What is a metabolic specialist? What kind of work are you doing?
Thank you for asking me to come and talk here. It's something is my bread and butter and very close to my heart. And the newborn screening, like the inherited metabolic disorder or biochemical genetics, that's my specialty. And that comes also some of the condition in the newborn screening. 6 out of the 9 conditions are screened for at the moment are metabolic, are my specialty. And Ireland, fortunately, was the first country to have a national newborn screening as a national service in the world. So Ireland started in February 1966, before any other country start as a national. It was in certain states in the United States having newborn screening, but Ireland was the first to start as a national one. And they started that in February 66, followed by New Zealand and Austria by the end of 66. UK started it in 68, so we are 2 years ahead of them. They did a pilot study first here, and they find it was PKU at that stage, phenylketonuria, and that was one of the condition was amino acid, which is a protein. So the biochemistry is whatever makes your body work and every cell of the body work. So that's what we look after. So it is a function of the whole every cell of the body, and that's how we live and that's how we function. So the PKU is one in the protein, and we eat protein, fat, carbohydrate, and the protein pathways. There is a problem with one of the enzyme, like it's like a seizure, cut the amino acid chain, which is a carbon chain, affects the phenylalanine itself. So become phenylketonuria, so phenylalanine raised there. And the natural history of the classical phenylketonuria is that the baby born normally, the baby over time accumulate much more phenylalanine, and that lead to neurological deficit and psychological problem, and lead to neurodevelopmental problems, and also so it become developmentally delayed. And they end the natural history, they end with seizure, epilepsy, in wheelchair, in nursing home. But since the newborn screening came, and that's more than 50 years, it's maybe 58 years at the moment, since that came, you can just give them a diet at that stage, was only the treatment was a diet, and that's to stop giving them the toxic substances, which is a phenylalanine, so give them only limited amount of it, and the rest, this synthetic amino acid doesn't have the phenylalanine, and they develop normally. And the majority of them, they achieve what's their potential. So at the moment, we have people, we actually, over the years, because of the screening and diagnosis, we had more than 900 patients or people with the condition. I say it now as condition because it's not affecting them to that degree. It makes their life much more easier for themselves, new developmental, and for their families, and for society. So they achieve what they want in school or in life and something. And some of them, they finish their living cert with nearly 600 points. Some of them, they have third level education. Some of them are PhDs. Some of them hairdressers. Some of them working. Some of them not working. In different aspects of life, in every place.
Yeah, yeah. They're fulfilling, as you say, their potential. They're leading a normal life now. But yeah, doing what all of us want to do.
Some of them, I didn't know that they have until I start metabolic, that they are actually metabolic, until I know that they are patient with us here, because before we used to look after the children, adult, and I used to see them in different aspects. Either they are nurses in hospital or teacher or something. I used to meet them. I didn't know that they have PKU until they came to me here. So, and that was the good part of about it, because since Guthrie in the 60s discovered the filter paper method, the Guthrie card, which you can do a test by only a few drops of blood at day 3 to day 5 of life, or day 1 to day 10 of life. You can diagnose that condition early in life before any damage happen.
Yeah.
And actually, when I met at some stage some of the politicians, as you're saying, and that's important to meet them, I met them just only to advocate for extra condition, to add to condition, and that was more than 10 years ago. And I told them, you're making money out of us, you're not spending on us, because you are saving a lot of money from that. Because the patient with PKU, the natural history, they will be in a nursing home. And nursing home for an adult patient will cost per patient from 100 grand to 250 grand, because they need 24/7 looking after. And that's these people now who have the condition, who are being treated, they actually, a lot of them working and pay taxes. At that stage was only diet. Now there is drugs for it also. There is Covan, and there is enzyme substitute therapy. So the diet at that stage will cost per adult person about 12,000 grand a year, 12,000 euros a year.
Yeah.
And any person who's working pay more than that. Because
unfortunately, we all know the feeling of that, all right. But yeah. No, I mean, it is amazing to think that we were the leader, that we did introduce this, and we've gone through all of the pain of setting up and getting samples from infants, and that most infants are now tested for PKU, and as you say, right, you just lead a normal life. And the history before, I met a woman recently who said that she was one of the first children in the country, one of the first babies in the country to be diagnosed with PKU, and she's leading her life. They have a restricted diet and stuff like that, but otherwise, as you say, you wouldn't know. You'd see them in the street and you'd have no idea that there was anything going on.
And I have seen patients who are much more older, like the eldest patient, the level was 86 to me, so that was a home. So I've seen both of who are being treated and having normal life, and people who are on nursing home, and that's it. So I told him, if we have 900 patients over the years, that will cost for service for the country if we didn't manage them or treat them. That will be about a couple of 100 million. And if you didn't give them the diet, that's only 10 million a year. So you're saving about more than 190 million or nearly 200 million from us. You're not really spending money. You're in the long term saving money.
Yeah, yeah. And that's just for one condition. So tell me then, you're obviously seeing lots of metabolic conditions, and I know, or lots of metabolic patients. And I know that many of what's been asked for, many of those conditions that are in that list of 30, 35 that NSAC is working with at the moment, are also metabolic conditions. So, it must be frustrating for you to know that, to see a child coming in that is now sick and
Yeah.
potentially has some type of permanent damage as a result of the exposures that they had. And it's kind of, if we if we had done this a few months ago, things could be different. That must be incredibly frustrating for you.
It's frustrating because for me and for the family and for the child himself. So for
Yeah,
and all the people who are working with us and all the society in reality, because the person could be having a normal life with some some changes, either medication or diet or something different, but just lead as normal as possible life, and then he might end by either encephalopathic or hemiplegia, paralyzed, wheelchair, cardiac problems, sudden death. All of that would be preventable. So in reality, public health issue that you prevent disease and you prevent mortality, morbidity and mortality. So it is saving the society and public health issue. Like it is very important from that point. So there are lots of diseases, the same story. The last one which we added, the last two metabolic, we add them in 2018, December 2018. And that one which I met the Taoiseach Antonish at that stage and the Minister for Health in 2010 to add that one, and took ages to add that one. One of
8 years. Ooh.
the MCAD, like because I have seen patients with MCAD who ended in being paralyzed and being damaged, brain damage, encephalopathic, and I know it's only you stop them from fasting. Just
Yeah,
if they have gone to theater or having delivery or have something, put a drip of dextrose, dextro drip, and if they have a gastro, take just only some glucose, something with sugary stuff, and you prevent them from fasting, and you need a normal life till whatever age. If you don't do that, there is all the statistics before the screening, it used to be about 1/4, 1/3 of the patient first presentation is death.
okay.
So there are loads of health issue, and that's a public health call really. And in the long run, maybe in the short term, you feel we're spending money now, we're going to expand screening. No, yes, you are spending money now, but you're preventing loads of millions and millions you're going to spend in the future.
Yeah, yeah, yeah. And you've got to say, I'm like, yes, you will be spending money now, but the majority of the money that you're spending now is in the lab, I guess, is adding tests to the lab. We are already collecting the samples. We already have, blood spots going to the labs and stuff like that. So a lot of the infrastructure is there, and the incremental addition is actually minimal. And as you say, there are treatments now available. I know one of the most recent recommendations was for spinal muscular atrophy. And there is a gene therapy there. They will be given it at 6 months or a year when they come in, but they've already had some damage. And it's like, you know what, we can get much better value out of this gene therapy if we give it to them at birth, rather than waiting for something, some bad outcome or some consequences. And it doesn't make sense. And morally, it doesn't make sense. Financially, it doesn't make sense.
No,
But
it doesn't. And in reality, as you said yourself, whatever in the lab, whatever we ask for 30-something condition, most of them are in the same kit we are using now. So
yeah,
the same machine, the same everything. And as you said yourself, we're getting the blood sample already. So it won't cost us much more money than that.
yeah, 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 yeah. It is. Yeah, I know that certainly the recommendations that would have come from you and your colleagues, you're already seeing patients, you already are providing treatment to them after you see them, and if you just saw them a little bit earlier, the treatment would be even more effective. So we already know that the system is ready to do this, but yet for whatever reason, we just can't seem to, I don't know, join up the dots. And it really, it's just frustrating. It really is just frustrating. But hopefully through this campaign and through raising this type of awareness, we'll be able to do something a bit more cohesive or a bit more instrumental. I'm going to just remind people that are online, if you have any questions, please do put a question into the Q&A. Professor Monavari or Ahmad, the other piece of work that I know that you're involved in, and I'm really interested in it, I think it's a critically important part for the rare disease community in Ireland generally, is around the European reference networks. Now, I know some people online may not know what they are, but essentially it's I guess networking expertise across Europe, rare disease expertise, so that, rather than patients having to travel to different countries to get access to an expert, their information and knowledge will travel to the clinicians here in Ireland, and where possible, that expertise will be used on the ground here. There will be some circumstances, obviously, if there's a particular surgical procedure that needs to be done, then maybe you will have to travel. But, to try and make sure that that information and knowledge is traveling first to the patient rather than the patient traveling to somebody. I know that you're a clinical lead on, I'm pretty sure you're the clinical lead anyway, on the metabolic ERN, European Reference Network. And I'm sure newborn screening is also part of that as well, in terms of, let's level the playing field across Europe. Tell me a little bit about the ERNs. Let's not tell me about the hopes for the ERNs. Let's not worry too much about the facts, the funding piece of it, because I know that's another challenge that we have with the HSE. But where would you see, if things were going to plan, where would you see all of this? What's going to happen? How is it going to change the way you provide care?
Well, it has an advantage for it because we have our own website for MetaBL, which is discussing the patient, but that one will discuss the patient in different centers in Europe. The all reference network, which means that the center has been audited, and they find him in that country, that center at the European standard, and provide a good service from diagnosis, from treatment, from management. And that's all that the member of the ERN. The advantage of it will be discuss the patient in our clinical email sort of things. We'll discuss different patient anonymously, and we'll get expert opinion from different places, and people could be expert in that condition, so they'll give you more thing, and then you find 3 or 4 or 5 knowledges going, and then we'll reach a certain agreement. The best option is A, or then B, and then C. And that will be benefit the patient from the diagnosis point of view and from the management point of view. It's had advantage because we also exchange knowledges, and also the center because there is a lot of rare diseases, and in metabolics there is nearly 1,800 conditions, and not expert in every condition and some sort of thing. So they'll ask you, we can go and visit a unit which is good in certain condition, and we'll exchange information and management. And we send some stuff, like from our unit here, we send some people to different units for either doctors, dietitian, nurses in different places. And people came to us because we are center for training for pediatric metabolic consultant here. So I have from other European country who came to train with us here for certain conditions. They never had it in their country, and we discover some of their patients have it here when they came to Ireland, because we have screening for it here. And they came, like one of their consultants is head now at the moment, and I don't want to mention who is, but she's the head of that in her country. And when another consultant was retiring, the new consultant came this year to train with us here. So we exchange knowledge, information, and the management person. And then we bring people to speak to the teams or the parent or the patients about condition. Like I'm invited also to different places. Like I'm going to Birmingham in November to talk to them about GA1, because that's my area of expertise. Glutaric aciduria type 1, which is a newborn screening one.
Yeah.
Experience here more than for really more than 40 years, and we start treatment before anybody else will start treatment worldwide. So we have a good outcome from that point, because we start management, and we said if you diagnose them early, you can have a normal life in comparison to have a CP life. And we
Okay.
so that will exchange information, exchange knowledge, exchange model of treatment, exchange everything to the best of the patients and affect parent. And then we'll see after that what other allied service helps in that situation. We might not have it here, we might have it in some other places. We were the first units in Dublin to have a play therapist, a play specialist with us. We did that from the States. So we did a pilot study in the 90s with that. And then we had our appoint one in 1999. And we have it since that time. But
yes,
the kids who were in long term here, that's it. Talk with the development stimulation and all of that sort of thing. So we might get with other ideas for things which are better. And
yes.
and then, like say, for example, now genetic counseling is very important, and different units have more genetic counseling than what we have here. So we need that. So that will come by exchanging that knowledge. So it will make it more harmonized in Europe and to a higher standard, to elevate everybody to a better idea. Yes.
Yeah. It's funny because I know we were at a meeting the other day and I made the comment that there's a perception that these are around, that the European reference networks are just for research, but really it's for raising the bar for everybody. For, you know, if you do have a challenging medical case, that you can bring it to, as you say, to your expert colleagues, and everybody, all heads come together and kind of like, oh, this, we think, try this, do this. And it just, you know, it seems to be just a no-brainer, really. And it's such a great way of, you know, I guess, dealing with rare diseases, because they are challenging. The diagnostic journey can be so long. What are the right treatments? And it's just, you know, as you say yourself, in the metabolic space, you can't be expert in everything in metabolics. You know, you certainly can't be expert across all 6,000 or 8,000 different rare diseases. And it just, you know, let's share all of that. You did mention when we spoke previously that you had also been involved in maybe a working group, I think it was, with the ERN around newborn screening, because as you've mentioned already, 6 of the 9 that are currently screened for in Ireland are metabolic conditions, and many that are on that list of 30 that we're waiting, hoping to get added over the next couple of years, that they are all metabolic conditions as well. So it's clearly newborn screening is a big thing in metabolic medicine. So what was that like, or what were people saying?
No, it was part of it was in Europe. Actually, it was in the European Parliament a few years ago when we had a meeting there, and there was a talk about harmonizing it in EU, but that's very difficult because there is no budget in every country to the same. So there is some countries which can afford only 2 conditions. There is some countries who doing between 48 to 58 conditions.
Mm-hmm.
So it's better, of course, if the more screening, the better for the patient and parent and the health service and for the population, the general population. The more the screen, the less side effects, the less sequel you have, the less problems, the less burden on the society in the future. So, and more near normal life you can have, and more better outcome you have. So it is frustrating from that point that there is no harmonization. But the whole story, you can't have it with different incomes and different national governments in different places. So we're not looking for harmonization, but we're looking for improvement to have it as much as better and more condition, more metabolic condition, that to prevent anybody that, as you said yourself, that you can see them with the sequels when they come late. Because the problem with that, we said, in one condition, if the damage happens, it's very difficult to reverse it. But if you,
Yes.
it's better to do it. So it is a preventative medicine. So
Yeah. I think it's a little bit ironic that, you know, one of the reasons that we don't have a bit more harmonization in this area is because, you know, it's expensive, or perceived to be expensive, although, as you say, in the long run it isn't. But yet Ireland is one of the worst countries for newborn screening in terms of the amount of tests that we're actually running, the amount of conditions included. You know, lots of Eastern European countries are testing for 20 or more different rare diseases. And it just, you know, it's kind of like, do they see the value in investing now for the future? Whereas we seem to be very slow to adopt that approach. I think I suspect our appetite for risk, and while this is not, in my world, this isn't a risky thing to do, but maybe there seems to be a bit more concern about, change isn't a good thing. I'm not sure what it is, but I guess that's part of what we're trying to do with this campaign, is to get that over the line, to move that needle and to say, definitely not. I have received a question, but I'm not sure that this is something that you'd be asked. Have you, do you know PANDAS? Have you heard that acronym before? PANDAS? No. Okay. Okay. Yeah, I thought as much. It's not in the metabolic or space. So if you want to come back to me directly on that question, and I will make some inquiries and see if we can get an answer for you on whether that is a rare disease or not. So that's very interesting, though. It's great to see the ERNs. I'd have to say, there is, I guess, again, a little bit like the newborn screening. It is something that we know needs to happen. It only makes sense. Research that we did a couple of years ago, 3 or 4 years ago, was 30% of people are saying they have no expertise. There is no medical expert in the country. And so, right, do we start, sending everybody overseas, or do we try and bring some of that information in and just enable local care? So I think, it just, it only makes sense, and it's getting to that stage. In terms of research maybe that's happening in the metabolic space at the moment, are there other conditions that maybe that there isn't treatments for today, but are there gene therapies and stuff coming along that you're kind of going, we need to make sure that we get newborn screening ready for some of those developments that might be happening over the next 5 or 10 years? Is there activity there that excites you as a clinician?
Just one thing, I want to let people think about newborn screening the same like immunization. As
Yeah.
vaccination prevent diseases, and newborn screening the same story. So it has the same effect from that sort of thing. The other one is prevent you to have the disease. That one let you to know it earlier so you can have a better outcome, just only that way. So if you want to expand immunization, vaccination, you have to expand also newborn screening. There is a lot of interesting things in inherited metabolic disorder. When I came first to metabolic disorder, there is only few management, and the most of them was by diet and some scavenger drugs, some drugs just to take the toxic substance out. Now there is some other medication, like Vicky, as we said, we have another stimulation to the enzyme. We have enzyme replacement therapy, we have enzyme substitute therapy, we have gene therapy, we have trials coming and going. There is trials which we are part of it here. So, and that's all makes the life easier for the patient and the whole story. Even the end of story, the research is not something esoteric and something think about it. It's only it reflects on the patient at the end of the day. It reflects on everybody to make their life better and to make their life easier and to prevent the side effects of any of the condition. That's the whole idea of the different management and research and that sort of thing. And in reality, even I have different ideas about newborn screening, but that's another place to talk about it. Like even I like it to be much earlier for some of them, and they like it to do twice on them at first day and second day of life, do it again week 6 of life, so we can capture all the condition which is early to be captured to prevent any damage, the condition which is late to be captured that we might miss it if we do the test earlier. So all of that to at least to cover it as much as possible. So just to have a better outcome for everybody and not to
Yeah. Well, I think we'll be keeping the National Screening Advisory Committee busy enough as it is. Let's get through what we want over the next couple of years, and then we'll start adding on some of these other things. And I know, some people I do hear talking about gene sequencing and stuff for newborns, and I'm kind of not sure we're at that stage yet. Certainly, we're not in Ireland, and there's a lot of conversations and stuff that need to be happening. But I'm interested to hear you talking about other types of, later screening as well that maybe we should be doing more of. I hadn't really considered that before, but we'll stick with newborn screening for now, as you say. Let's not complicate the story too much more. I don't know if there's any other questions that anybody wants to ask. I'm happy to try to answer. And of course, if anybody, if you do have a question, and if you want to email anything directly to me, advocacy@rdi.ie will get me, and we'll try and answer any questions that people have. If there isn't anything else coming in, I might think that, is there anything else you'd like to add, actually, before I begin to wrap up? Is there any topics that you think we should think about, or what?
The newborn screening, we're doing the biochemical method at the moment, but genetic method is also part of newborn screening.
Yeah.
And it will come here because also there is certain kits to do newborn screening with genetics to certain condition, and certain condition will be genetic testing, and we're happy to do that. We are ready to do it at any stage that we need to do that. And
Yeah.
in some condition in the newborn who are sick in the ICU, newborn in neonatal ICU, we do genetic testing quickly to try to find what's the underlying condition. And that's okay. And what I'm saying about early and late is still newborn screening, all of them, not in few years time, we do it in few days time more. Then
Yeah.
about that. So in 24 hours and in day 10. So all of them is still newborn. But
Yes.
to brush everything without missing anybody. Just only to give everybody an equal right to be diagnosed and to be preventative. So and to do the preventive medicine. So
And I think that's a very interesting comment. An equal right, equitable access. It's kind of like by dint of some happen chance, you're living with a rare disease, and because yours doesn't manifest itself within 72 hours, but it happens, at 120 hours, does
well,
that not mean that you should be afforded the same opportunity to get an early diagnosis and access to treatment as quickly as possible? Absolutely. And that's what we should all be asking for. Clearly we have a lot of ground to make up in rare diseases if it's taking on average 6 years to get a diagnosis. And I know some of those are potentially people where the condition hasn't even been identified, and that's what some of that causes. But for many people, we know actually the conditions are identified, and science is there, but we're just not good enough and quick enough at picking up on it and getting the right diagnosis. And I think, yeah, it's absolutely, it's only fair that everybody's given the same opportunities. I would just remind everybody again, please do visit our getrareaware.ie website. And Professor Monavari, Ahmad, when you leave in your office there, tell everybody to get on and drop a quick email. It literally only takes a couple of seconds. It's just a name and an email address. That's all they're looking for. And just to show the politicians, people that are sitting in the Oireachtas, you really do need to do something about this. It's not, it's, it is a relatively simple, straightforward way of really improving outcomes for people living with rare diseases. And it makes sense in every aspect, in terms of the person living with a rare disease, their family, the healthcare system, the clinicians, everybody. It just makes sense. So we really do need to make sure that we do get everybody on board. But I do want to thank you very, very much for your time. I know that we have a meeting next week in the Dole, and we'll hopefully generate some more with that, and hopefully we might see you and some of your colleagues there. And to all of our guests online, thank you very much for coming online today. And I hope that you will take the opportunity when the elections come around, when the national elections come around, to ask the candidates, as they're on your doorstep or as you meet them on the street, what are you going to do for the rare disease community? Please do something for newborn screening. That we really do need to keep this at their forefront of their minds, particularly that we need the support. We need as much support as possible. We're pushing hard now that we will get our new strategy in place, and that there will be align in the new programme for government, or the next programme for government, that will deliver on some of our asks, because we're the forgotten community in many respects in terms of healthcare, but we don't want to be that anymore. So without further ado, I'm going to wrap up the meeting.
I want to thank you for your whole campaign and your great work, and let's make it in the agenda and through the politician and the media and everybody else. That's great for us. Great for
yes.
us.
Absolutely. Well, listen, we thank you and your colleagues for all of the work you do. I know it's not an easy job, but we do want to thank everybody. And listen, thank you very much to everybody, and we will see you again soon.
Bye-bye.
Bye-bye.